my long-term condition actually is one of the ones, it was actually a mental health case as well. So I just put it for the long-term condition. It was someone with known long-standing depression that was now getting side effects from their SSRI. So we had to discuss changing her medication. And my over 65, I actually ended up submitting a gentleman who was having a flare of gout, and we were able to discuss prophylaxis as well. I found with the over 65, this was a category I was really, really struggling with getting within the time. And I actually found musculoskeletal and joint problems were quite a neat way of having something that really it really impacts anybody, but it could impact the elderly more if they can't get out and about at the moment with such delays for joint replacements and things. So I actually found that was quite good. And just talking back about doing things over and over, I think maybe focus on one joint of the body and get really slick at that. So then all the shoulder pains or something, I did not think that it was passable. They were all, mainly because 12 of the 13 were over the 12 minutes. And yeah, I mean, they were all over 13, 14 minutes, but obviously you've got your introduction doesn't count in that time. So actually I found it really encouraging that they were passable, because I think it shows that they are looking at the consultation as a whole. And I had actually made some point of trying to get the management in a bit earlier. If someone mentioned something, I would try and address it there and then, because I just knew I had a tendency to always be over time. I actually wasn't going to submit. I didn't apply for the September, and then in the November, I thought it's such a lot of money. I'm going to pull out. And my half just said, just give it a go, just submit. My trainer the same. So yeah, I did. And I think it is a reflection that they really are just looking for your day-to-day. They really do want us to get our licensing. They just want us to be sensible and safe and interested in the patients. I think that was probably my strength, which is why it would impact my time management.
Welcome to RCA in Focus. In this series, we dissect the strategies, tactics, and tools to help you crack the RCA. My name is Dr. Owen Kwan. I'm your host, and I'm on a mission to help doctors lead a happier and more fulfilling life. In today's episode, I'm joined by a GP registrar who cracked the RCA first attempt. Dr. Hannah Phil overcame a number of challenges, working less than full-time and going through a pregnancy while sitting the RCA, and she passed the RCA with flying colors. If you want to learn the strategies she used, her process, and how she managed to build her confidence and get all her cases, then stick around. Hi Hannah, welcome to RCA in Focus. How are you doing?
I'm good, thank you for having me.
Could you tell us a little bit about yourself, Hannah?
Yeah, sure. I'm a GP ST3 down in Surrey, and I am less than full time, so I do 50% because juggling 2 small children. And I sat the RCA in November. I was planning on taking it in September, but I decided that I wasn't quite ready, so I deferred it.
Thank you. So yeah, that's one of the things that many people are not sure when they're going to take the RCA. What would you say in hindsight would be best way of deciding? Because sometimes people feel they're not ready and they have to postpone it.
So when I say I postponed it, I hadn't actually paid for the first exam, because I think the danger is the cost if you then just personally don't feel ready. I was about 5 months full-time equivalent into my ST3 when I started recording and preparing for the RCA. I delayed it that much, I think, because I was almost hoping that the CSA might come back, because I'd just returned from maternity leave. But I actually, in hindsight now, I think being 5 months in was actually really helpful, because I just felt like I knew the structure of how things were working a bit better and felt a bit more confident in the practice. And so it's hard. There's no ideal time to take it. But I actually think that waiting a little bit later in your ST3 year might give you time to feel a bit more confident, think up some strategies, go over, be confident with your management. But I appreciate there's the argument of sort of trying to get it out the way.
Yeah, there's pros and cons in each approach. So you decided that you were going to do it in November instead. What fears did you have about the exam?
So I really struggled with the timing of the exam. Particularly, I actually, it's slightly complicated. I had to move practices, and I had been in a practice that was doing 15-minute consultations. So that was the norm. That's what every GP was doing. So to then be trying to record, even though it's now increased to 12 minutes, I found really, really challenging. I'd also that summer finally had a formal diagnosis of dyslexia, and so I did find the note side and word finding quite challenging, especially when being having a time constraint on that, as well as a sort of listening back to everything. I've forgotten the question, Owen.
So we're talking about the fears that you had about the RCA.
Sorry about that. Yes, so I was really worried about getting my consultations under time. And I think because I felt quite comfortable with the data gathering, I was just focusing on that. And I just had a crisis of confidence when I was going to pay for the September exam, that I just didn't have the right cases. I didn't feel I confidently had anywhere near the mandatory ones. So I decided, I've got 2 more months. For me, I was also in the 3rd trimester of pregnancy, so actually deferring 2 months meant quite a bit. It meant it was getting ever near my due date, so it was a big consideration, and it was a bit of a stressful time, but we got there in the end.
I can only imagine how stressful it is, because you're having to juggle through the RCA, your training, and then family commitment. So tell us a little bit about how actually did you prepare, because given all these moving parts and you're having to focus on an exam?
Yeah, well, I think I knew right from the beginning that I didn't really have a lot of slack to give extra time to this exam outside of work. So I sort of knew that I had to build it into my working day. And so my time outside of work was very much for going over guidelines and working out management plans and sort of creating resources that I would find then useful. And then it was really just trying to optimize the time that I had within the practice, which I can share if that would be helpful.
So yeah, share a little bit about what sort of strategies you implemented to actually maximize the time.
No, absolutely. So I, as I said, I was 50% less than full time, but I did a duty session once a week, which is where actually I got the majority of my cases. I think because they're people sort of presenting normally with only one problem and wanting something that day. So you are going to be discussing some form of management. I would use my commute to and from work to listen to recordings. So the recordings I'd done that day, I would listen to on the way home through I've got a USB lead thing, and I would listen at 1.5 speed just to try and see the consultation as a whole, if it was within the time was my main thing. Sometimes I would even zoom forward to about 12 minutes and see how much where it cut off. What else did I do? I initially tried using an Excel sheet to try and keep track of my consultations, but I actually found you could work quite smart with the RCA 14 fish platform. I was really cautious about how I recorded the name, even just the name of the consultation, so that I could then reference it back really, really easily. So if I did it as a numbering system, just that's how it worked for me. So 1s would be mental health, 2s women's health, that sort of thing. And then it was really easy just to see exactly what category that case would fall into. There's probably some other things that will come up along the way, but I think the main thing is that I really just had to see it as any normal consultation with a patient. I didn't have time to do anything additional.
Yeah. So you try to integrate things through your daily activities to make sure that you were optimizing for that time. Mindset is very important, and you mentioned about confidence crisis. Could you tell us a little bit about your mindset at the start when you were trying to record?
I think I found it quite overwhelming. I really struggled listening back to myself. I think a lot of people have that fear as well, especially as medics. We want to be saying the right things and doing the right things, and it's amazing the things you hear yourself say or suggest when you're watching yourself back. So I really just didn't think this was a hurdle that I was going to be able to get over. I thought if I had 15 minutes, then maybe it was more achievable. But I think I really struggled to see myself as the doctor. I think throughout my training, you've always had a senior, you're always a trainee. And actually this exam, one of the things I really had to learn was actually this exam is not just another exam to get through because I have to. It's an exam to actually let me be licensed as a GP. And I had to really see it as something that was going to give me another step up in my career. And it's, I really did have, you're right, mindset. I really had to shift into that. Actually, this could be me in a few months' time on my own with this patient. So actually, I need to take responsibility for my learning and knowing the management plans, where to look for resources and things.
Right. So that shift in mindset helped you. Could you tell us what are the things that you've done to help build your confidence? Because it's very difficult coming from a place where you're not confident about your management and how you consult, and then to actually do it and then be able to get cases that are level to what we're expecting for a clear pass.
So one of the things I probably should have mentioned in my preparation was I decided to explore different courses for the preparation. I just knew I needed to use my time efficiently, and that was where I came across your one-to-one coaching, which I think was a real, it first highlighted the confidence issue, I think, and I decided to try and get the mandatory cases first, because I felt that would give me a bit of a confidence boost if I knew that the ones I have to submit I had some consultations like that. Then I felt like I'd be moving forward, rather than it can be very disappointing to keep doing recording after recording and thinking, no, I can't use this, I can't use this, I can't use this. So I also did give myself some breaks of recording, and it was really nice to see follow-up patients because then you knew the pressure would be off. I'm just trying to think what else. Yeah, I think those are the main things, really just trying to focus on the mandatory criteria. And to be honest, I actually ended up using cases from those topics as my extra cases. Something you mentioned, actually, I don't know if it was on your course or in our coaching, about trying to maybe do a topic a week or something, see a run of chest pains or see a run of headaches. This really, really helped me. It wasn't possible for me to orchestrate that, but I found I almost did that with the mandatory cases. So I became so much more confident with mental health, with women's health, because I was, talking about HRT until I was blue in the face. And I think you just get a bit more comfortable and confident, and things just roll a bit smoother. So I think this is a very long-winded way of saying exposure, seeing more patients, talking through things, and away from that, thinking about how you're saying things. I actually had crib sheets for myself, possibly because of the dyslexia, but to literally read. At the beginning, I was sort of reading off, but as time went on, it was just much more natural.
Absolutely. I think having exposure is very important. And as you said, when you're doing case of chest pain for the 10th time, you're probably going to do it better than when you were doing it the first time. So one of the things that we did talk before was about focusing on the progress, because sometimes what happens is that trainees focus on the things that they're doing well, and then this can help them to build confidence. Can you tell us about how you are getting your cases and the trap of not trying to chase for this perfect case?
So case selection is the point everyone gets a bit caught up over, and I found this really hard because of having reduced clinical time. I mentioned the duty session, and that was really helpful because I was supernumerary, so there was a designated duty doctor, and then I was chipping in, which helps them as well. But that was where we would always have mental health cases coming through there, and we'd always have a chest pain. We'd always there's certain things that, and there's always children as well. So that was a really helpful way of getting cases. We had an online system called Pitfalls, where people would put in an online request, and I would screen them in the morning just to see if there was anything. And actually, I think quite a few of my menopause consultations would come through that. Someone has been thinking of finally to consolidate their symptoms and put in a request. So I would take those. I also asked colleagues if they got any abnormal blood results. So, for example, an HbA1c that was sky high in someone that wasn't diagnosed, so that I could explain that. I think I explained a high BNP and what we would then do. So it's really just trying. I ended up casting the net quite wide. I actually started recording in the July, hoping to do the end of September, and I ended up doing November, but I was able to use some of the cases actually from right at the beginning, because of the time scale.
Thanks for sharing that. So one of the things that you mentioned about discussing abnormal blood results, one of the concern that some registrars might have is that if they're doing follow-up cases or review, how do you decide whether this would be suitable? Because sometimes what happens is that the history is taken in an artificial fashion.
Yeah, absolutely. And I think the main results giving case that I actually did submit was an ultrasound result showing fibroids. And this then gave the opportunity to ask what the current symptoms were. And I think I ended up starting tranexamic acid or something. So there was then management in that, and there was plenty of data gathering to see how it was impacting her life and what the options were, and whether we would consider referring to gynae, or if we wait and rescan and things like that. So I think it very much depends on the context. So with something like a raised HbA1c, it would depend on whether the patient, was a diabetes expert, or if they'd never heard of it, or if it would be a huge impact on their life, I think. Because actually another one of my cases was a request for sleeping tablets, but it was actually someone who had a really traumatic event, and it turned out to be sort of post-traumatic stress. So whereas that might have been a simple case, it then became a bit more complex, and my trainer felt could be submitted.
Right. As we're discussing the cases you submitted, could you talk for us each of the cases that you submitted? Because that would be very helpful for the audience who is listening and watching this.
Yeah, obviously, I don't know. You can't listen back to the cases. The ones you submit, they sort of go from the platform, and I don't know. They don't give you a mark per case. It's all an average. But my mandatory ones, I had a 7-year-old with abdominal pain that I submitted as my paediatric case, because we discussed about stress at school, as well as mum really thought it was appendicitis, and it allowed us to sort of discuss the options and then bring in shared management with saying to mum if she felt okay, if we watched and wait, it was probably constipation, that sort of thing. I've mentioned my mental health case. It was a sleeping tablets request. My long-term condition actually is one of the ones. It was actually a mental health case as well, so I just put it for the long-term condition. It was someone with known long-standing depression that was now getting side effects from their SSRI. So we had to discuss changing her medication. And my over 65, I actually ended up submitting a gentleman who was having a flare of gout, and we were able to discuss prophylaxis as well. I found with the over 65, this was a category I was really, really struggling with getting within the time. And I actually found musculoskeletal and joint problems were quite a neat way of having something that really it really impacts anybody, but it could impact the elderly more if they can't get out and about at the moment with such delays for joint replacements and things. So I actually found that was quite good. And just talking back about doing things over and over, I think maybe focus on one joint of the body and get really slick at that. So then all the shoulder pains or something, you can then just keep doing that rather than doing a shoulder one day, back the other, knee as in thinking of cases for the RCA. I found that helpful, but it's obviously up to everyone else. My acute case was hyperglycemic patient that I actually admitted to hospital. And my women's health was one of my many HRT discussions, the one that I thought contained the most within the 12 minutes. And then my extra ones, again, I had a sort of women's health, I imagine. It was a breastfeeding lady with thrush for both her and the baby. And in this instance, she'd already on treatment, but the baby hadn't been treated. So there was a chance it was going back and forth. I've just said about the fibroid results. That was one of my extra cases. I had tired all the time. These are things that I was consulting with almost every day I was at the practice. So tired all the time, migraine, unintentional weight loss, and PR bleed, and a relative for an end-of-life care discussion. That's a bit of a haphazard way of my 13, but overall, it's really just the things that I was seeing once I'd got those mandatory criteria. It was really things I just felt more confident in, and those were the sort of cases that I ended up.
Sounds like you've got a good selection of cases, interesting cases, and you've managed to actually bring things in each case where there's some angle to it, where it's going to help you to score. So talk for us about how you benchmark your cases, Hannah.
So just before saying that, I would just say one of my pitfalls, I think, was almost getting too interested and finding the really complicated patients. I found it actually really hard to just draw a line and say, no, this is too complex and not get too interested. So don't fall into that trap. So my cases, I'm very much paper and pen person. I had a printed mark scheme. A friend had actually made it that basically just said the different points for the 3 areas. And as basic as just ticking if I felt that I'd met that statement, and whether I felt that, it was things like, the patient was able to share their views and things like that. And I had to note the timing, how far after my introduction, how far over the 12 minutes I was, because all except one of my 13 consultations were over time. And then I would sort of decide whether it was possible to submit it, and then I would get my trainer to listen, or if at the moment I just didn't think I thought I could really get something better. And those cases I would call a reserve if I thought, there might be something I could fall back on, and I would put an R in the name so I could see it easily on the 14 Fish platform. And if there was one that I knew was, too far over time, however, empathic and nice the consultation was, I would delete it from the platform, which was quite tricky to do because when you delete it, it's completely gone. But I think again, talking about the time management, to just have it gone and know you don't have to then be dithering with that consultation, I found helpful.
So thanks very much for talking about these things that sometimes people don't realize. Now, with regards to your trainer, how did you develop a good working relationship? Because I've had trainees asking me about advice because they've had issues, and sometimes trainers can be busy. What would you say are good things to do to make sure that I have a good working relationship?
So it's really tricky, and I totally can understand. It's so frustrating about this exam that it can be so practice dependent. Just before mentioning my trainer, my practice, I wasn't actually able to get the receptionists on board. We'd had lots of staff sickness and turnover and things. And I'm sure that is something that I hear regularly about the RCA that can really help you with case selection and talking to patients. But I think this ties in with our trainers because it is our exam. And I know our trainers can be a huge asset. And mine certainly was with the case selection. But at the end of the day, it's us that submit, it's us that pay for it, and it's us that judge the standard of what we're submitting. So I had quite an open chat with my trainer at the beginning, basically saying, my life's very busy. I need to try and get this exam before I go off. What can you offer me as support? And he basically said, I'm prepared to listen to 4 cases a week. I don't know if that's a lot or not a lot. That was just what I was told. And so that's what I was aiming for each week. I was like, if I could just get 4 that maybe might be submissible, or less. And it did waver. Some weeks were less, some were more. And he agreed that to use all of my tutorial time to then go over those cases that he would have listened to. He said he would just listen to them whilst walking the dog, a bit like me using my driving time. So, and I very much was trying to say, look, if I can get this exam out of the way, then hopefully, you know, my timings will be slicker. I'll be able to help a lot more. I also negotiated that 1 duty session a week, which I think most of my 13 cases were from.
Right. It's quite common for GP registrars to find that when they're on call or on emergency, then they get quite good cases. So it sounds to me that that discussion with your trainer in the beginning really helped to set the tone and how the arrangement would be so that there is mutual agreement. So in terms of the clinic then, how many patients were you consulting per day, would you say, Hannah?
Oh gosh. So the background of this is I only do 1 full day because of my timings. I actually can't remember. I went on maternity leave in November. I'm so sorry. I think it was about only 7 or 8 in the morning per session, whilst I was trying to do this exam. So although I say the practice weren't able to sort of help me with the actual booking and finding patients, they were supportive to sort of let me have, you know, more gaps in the morning or the afternoon to allow for the recordings. I was also telephone only because of shielding, so that caused a bit of a snag because I would have to beg colleagues to see patients that I thought really did need an examination. But that was actually, in hindsight, possibly a positive, because it really made me think, do I need to examine this patient? Do I really need that information enough that they're going to come in and see another colleague and that they're going to be at risk potentially? So actually, I think I found that really helpful. And just in general, I think as registrars, hopefully, we'll be more confident with our telephone consultations than we might have been in a pre-COVID era with our training.
Yeah, it definitely make you think more when you're having to take more steps. Tell us a little bit about when you submitted all your 13 cases. What were you expecting then?
I did not think that it was passable. They were all, mainly because 12 of the 13 were over the 12 minutes. And yeah, I mean, they were all over 13, 14 minutes, but obviously you've got your introduction doesn't count in that time. So actually I found it really encouraging that they were passable, because I think it shows that they are looking at the consultation as a whole. And I had actually made some point of trying to get the management in a bit earlier. If someone mentioned something, I would try and address it there and then, because I just knew I had a tendency to always be over time. I actually wasn't going to submit. I didn't apply for the September, and then in the November, I thought it's such a lot of money. I'm going to pull out. And my half just said, just give it a go, just submit. My trainer the same. So yeah, I did. And I think it is a reflection that they really are just looking for your day-to-day, that they really do want us to get our licensing. They just want us to be sensible and safe and interested in the patients. I think that was probably my strength, which is why it would impact my time management.
Yeah, so would you like to tell us what was your score, Hannah?
So for both data gathering and management, I got 56 in each area. And then in the interpersonal skills, I actually got 70, which gave a score of 182 out of the 234 points. And the pass mark for that cohort was 142. So yeah, I was very, very pleased with the interpersonal skills.
That's a very good score for somebody who thought that the cases were not going to be possible. Tell us a little bit, what did you do to score so high in interpersonal skill?
So I don't think it was really a conscious thing. I think it really was trying to be interested and putting myself in the patient's position and thinking like, oh, how would that impact me if I was doing that? I did, like most people, I think, have a bit of a list of how's it impacting them? What are they worried about? What are they concerned about? To ensure that it was covered. And I also did try and get that context quite early on. It's something they say on the RCA package about asking the ICE right at the beginning. That never really felt natural for me, but I do think there's a real benefit in having it earlier on in the consultation, just so then you can, when you're discussing, I don't know, bringing them in for an exam or something, if you know they've got an autistic child at home, then you know childcare might be more difficult or something like that. So yeah, just having the context is really helpful. So I tried to get that early in general, and I just think it's about being interested. And people have so many stresses and things going on at the moment. It's probably from an RCA point of view a good time for challenging cases, I think.
It's something that really makes a difference when you have a doctor who is really curious and want to know about the patient and really care and show that they are supportive, and somebody who is doing something that's robotic and just going through a list. And it sounds to me that you actually brought this human aspect in the consultation, and that's something that is something that people can learn. What would you say things that people miss about with the RCA? What are the things that you think some trainees might not get?
From an interpersonal point of view, do you mean? Or just I think it's like exactly like what you said, being from a checklist or just using those same recycled phrases. I think one of the reasons I probably ended up becoming more natural, remembering I've recorded over so many months, I actually realized a lot of the time when I wasn't recording were my best consultations. And you think, oh, why didn't I record that? So actually I started then just recording everything. And I wish I'd done that from the beginning, because it just then became more natural. I was just expecting to be recorded. Some practices, I think the telephone consultations are recorded anyway. But I think just really trying to shift the mindset from I am working towards an exam, I need to do this, 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 and this, to actually there's a patient that is consulting me because they want my advice. They want to know what I think is going on and we could do, and I can help them. And again, I think it's that whole just shifting that view of I need to get through this exam because it's the next thing to do, which is, as medics, what we're normally like, I think, to actually this exam is going to help me. And I found it so valuable to have the most feedback I probably ever would have got from a trainer who's, listened to actually quite a few of my consultations and can pull me up on things. Whereas actually without the RCA, without the recordings, those would have gone unheard just between me and the patient type thing. So it's hard. And I appreciate I'm on the other side of it, but I think if you can really try and embrace it as just part of your day and part of a step up to get you to be a qualified GP, I think it can be really, really helpful.
Definitely, that's a very good point. And certainly the clinical management is a part where you're impacting the life of your patient. So many trainees actually procrastinate and they rush through their clinical management. What would you say about things that you've learned to make sure that you have a good clinical management, Hannah?
So I think a big, and again, a point I think you picked up in our one-to-one was that I was putting the examination within the clinical management, and exactly as you say, I was stalling because I felt comfortable asking questions and finding the story. As soon as I tacked the exam in with the data gathering, that already saved me some time in clinical management. But I actually did spend a lot of time going through each topic area and sort of looking at the CKS guidelines. And I mentioned these crib sheets. I had sort of, headaches. I'd have like the main causes of headaches and what the management would be. And to be honest, a lot of these with the body systems, it's very similar things. You know, you watch and wait, there's lifestyle advice or things the patient can do themselves, or there are investigations you can organise, or there are referrals that you can ask for other people. So I sort of had that structure for my management. And another point was early on, I realised I wasn't actually committing to a diagnosis. It's a very scary thing to do, especially when I'd always been under my trainee banner. But actually, I think that made a huge difference when I sort of try and say with confidence, I think this is what's going on. It might be this or this, but if it's this, these are the options. What do you think? And I think what I'm trying to say is the main things that you can do, the patient can do things, you might be able to do things, does this, that, and then other people might be able to do things. So allied health professionals, specialists at the hospital. And it's actually the consultation, all of them are, you get a lot of duplicates, I think.
That's very good. Yeah, I think it's very important to actually be able to do that. And one of the things that you talk about is to be interested with your patient and know about the context. How do you integrate that in your management?
I think, so an example would be my acute case. It was an elderly lady with hypoglycemia going into hospital. And with that, we were able to discuss the risks of her coming to the surgery, just to see if we could check her over, see if there was any source of infection or something we could manage, because of the COVID risks as well of going up to the hospital. It was very helpful that her daughter she was with her daughter, so was able to then involve her daughter into that. I think it's just almost trying to think outside the box, and a bit like I said, just putting yourself in that person's shoes. So, okay, I'm an elderly person. There's this COVID pandemic going on. I'm not too fussed about my high blood sugar, but the doctor's telling me to go into hospital. Is there another option? Yeah, I think it's really just, again, trying to think what you would do, or what you would advise if that was your grandma, or if that was like a really good friend asking you for advice or something, or if it was you, what would you do or think about?
So thinking from a patient's perspective, making the consultation more patient-centered, that helps you in your clinical management. So tell us a little bit about things that you wish you'd do different. You've already mentioned about recording all the consultations if you could. What other things would you say?
Yeah, so exactly. I wish it had just made the recording naturally right from the beginning. I also think it's another contentious issue, but using the 14 fish recording, I'm not so sure I would do that, certainly early on, because I ended up using a lot of minutes and buying a lot more minutes. And the flaws for me, one is that the cost of the minutes, and if you record off the platform and then upload it, it just takes 10 minutes, even if your consultation is 20 minutes. And as you probably picked up, mine were normally in the late teens. But also, I've learned quite early on that if you stop recording on the platform, it drops the call. So although it's great that it does the consent for you, and I would actually just use Accurex to text the patients to say, I'm recording my consultations. The first voice you'll hear will be an automated message asking for you to press 1 if you consent and 2 if you don't. And I found that a real time saver. I just literally copied and pasted that into Accurex. So you can get around the consent thing by, contacting your patient saying that, or just saying it when you're recording on another device. Because this sort of does tie in with the mindset that I just had to accept that some consultations were just not going to be RCA-able. I just had to, and for me, it would have been really helpful just to press stop and just then deal with the consultation and draw a line under it and move on. Because you will get really chatty patients, and you will get much more sort of slick patients that come in with one problem and just want you to help them there and then. So I think that I would possibly record on a different device and then upload the ones that I thought I should share with my supervisor. And that would also help, I think, with the management of your cases on the platform, because I imagine if I was doing a lot more clinic time and a lot more recordings, that would have been quite time consuming and challenging.
That's very useful. So in terms of the RCA then, what would you say would be unhelpful advice you might have got? Because there's loads of advice that people hear.
Unhelpful advice. I think I've tried to streamline it. I think about really almost focusing on the interpersonal skills, I think actually sometimes can be a negative, because then it can seem quite forced. So I'm trying to think what other advice I had. I did have certain people actually advising certain cases that I just knew weren't to my strength. I would try and record a lot of, vertigo or back pains and things. But you could almost tell that I was trying, it sounded like it was a case for the RCA, so I was almost trying to make it into that. So I think more focusing on your own strengths is helpful. I don't think I can't really think of a lot of things I got off. I know there's some people saying, do all telephone consults because then you'll get better marks. There's that argument of telephone versus video. My circumstances meant it was all telephone, but I have heard that video consultations actually you can get a lot more because the examiner can actually see your expressions even behind a mask.
I think that's good. I mean, it's good to hear what has worked for you and what hasn't worked, because what might work for somebody might not work for somebody else. So it really needs to be taken with a pinch of salt about taking advice from other people. Now, in terms of the resources that you've used, how did you go about deciding which resources are going to be useful or not?
So resource-wise, I think the go-to is CKS because it's quite neatly outlined. I used actually some of the things I'd used from AKT, and I should have mentioned it probably when talking about the timing of the exam. Actually, there might be a benefit to having done the AKT more recently than I had. But the main thing for me, I think, was courses to see so I could actually get practice. This wasn't an exam to prepare for like I would have done for the CSA. Just for context, I was preparing for the CSA before my first maternity leave. So it wasn't one where I knew I could meet up with colleagues and practice. So I used the RCA package on the 14 Fish platform. That's really good for clinical management. There's got some example videos, and then I was just looking on YouTube, which is where I came across you and your blueprint course, which was really, really good, and gave a little coaching session with it. And then I thought, as I said, I just need to kind of throw everything into this exam. So actually, for my situation, I think having a one-to-one would be really, really helpful and a more safe environment. I also did the RCGP course, which was helpful because it was actually examiners for the RCGP. So there were examiners that were teaching the course, and then they had actors with other examiners, and that actually taught me. I had a scenario that I did quite well on the course of a bereaved gentleman, and that was basically all it was. He'd lost his wife, and I think it was probably that I was acknowledging that it was sort of an extended grief reaction rather than a major depressive episode. But I honestly felt like I just had a chat with him as if it was, a friend who just lost someone, and that actually scored quite well in the course. So that actually was a bit of a turning point to think, actually, maybe they are just looking for us to be human, and it doesn't necessarily need to be a really complicated case where you're changing all these medications and things. So
thanks for giving such example, because I think this is the essence of the RCA. They want to know your skills, how you actually interact with somebody else. And sometimes if you focus or overthink about the technicality, then you're probably not going to do well for the RCA. So thank you very much for your insights, Hannah. It's been really useful, I think, in terms of what your journey has been and how you actually managed to overcome all these challenges. So last word of advice for somebody who's going to go through the RCA and trying to get these cases. What would be the last thing that you'd say?
Well, I wouldn't actually say good luck, because this is definitely a passable exam if you are practicing how you would once you are a GP, a fully qualified GP. I would say just keep it simple, focus on your own strengths, and just try and embrace it as your everyday, because if you think of every day as an exam, then it's just going to be such a stressful time. And you know, we've all got busy lives, so we need to sometimes leave work at the door. Yes, you need to do the work for you to have your clinical management up to date, but equally, you know, you've been working really hard over years to get to this point, so have confidence in yourself and just keep it simple and focus on those simple areas that you can do well.
Thank you very much, Hannah. Thank you for watching until the end. Take care, everybody. Bye-bye. If you want more videos like this, then make sure you smash the like button. If you found this video useful, then I've got another video which I'm sure you're going to enjoy. Click the video here to watch it. Take care, everybody. Bye-bye.